We're going to discuss the history of CT, how it all started, how it's done, and the fundamental principles. So CT, as you all may be aware, has become a revolutionary tool in the medical imaging arena. CT is the most ordered exam out of all the other modalities. It's a very money-making modality. And like I said earlier, we're going to be discussing the meaning of CT, how it started, principles, and the history. All right, so the word tomography in computer tomography is not new. It can be traced all the way back to the 1920s. At that point in time, x-rays had been already around for a while. So all these scientists were investigating, how can we make 3D x-rays, so to speak. So they were already in developments, trying to figure out how to take different sections and layers of the body and piece them together. So originally it was termed body section radiography. In the early 1920s, the term was used to describe a layer of your body. So, like I said, a number of investigators were already developing new methods to acquire these 3D x-rays. And then when we moved to 1935, the term was changed to tomography. It's derived from the Greek word tomos, meaning section. And in 1937, the term changed to transverse axial tomography, referring to the ability of the 3D or the CTs to be cross-sectional images. All right. By the way, I will send this PowerPoint out, so you guys don't need to rush to take notes. All right. Notable contributors that revolutionized CT. This right here is Mr. Hounsfield. Remember, Wilson talked about the Hounsfield unit earlier. That comes from his name. And also we have an image here of an early CT scanner. Looks kind of crazy. So this, you could only image your head, and it took about 5 to 10 minutes. Nowadays, a CT head takes like 3 seconds. So this was like very, very slow, and you could only image the head. So let's see here. So the first clinical CT scan on a patient took place all the way back in 1971 in London. The patient was a lady with a suspected frontal lobe tumor. And the CT scan of the head right here was developed by this scientist, Mr. Godfrey Hounsfield. Some fun facts about him. He was born in England. He worked for a research company called EMI Limited, and he discovered that measuring x-rays passing through an object from different direction, you can turn it into 3D slices. And his research contributed to our first CT scanner, and he received a Nobel Peace Prize for that. Another scientist that contributed to CT is Mr. Alan Cormack. He was in charge of solving the complex mathematical problems when it came to CT, and how the image was acquired and how it was processed. And he was responsible for developing the solutions to the mathematical problems that they had in early CT development. So in 1963, both Hounsfield and Cormack worked together, and they put the mathematical problems together, and they figured out how to get these CT images to be reconstructed. So when a CT scan is done, what plane is it scanned in? Axial, right? So these complex mathematical problems allowed them to get image reconstructed into sagittal, coronal, etc. So this revolutionized CT, and then today we now know it as computer tomography because it uses complex computers, correct? Everybody good so far? All right, so we know that CT produces sharp, clear, cross-sectional images of the human body by reconstructing a large number of projections from different locations. So As you can see here, we have multiple detectors taking pictures from different directions, and all of that is placed together and created into 3D images. So the idea of image reconstruction was originally derived in 1917. You don't need to remember all this. When mathematician Radon proved that 2 or 3 dimensional objects could be built up from several projections from different directions. And then in the 1960s, image reconstruction from projections proved useful in other medical applications such as nuclear medicine and CT. So there's some steps involved to CT scanning. There is the data acquisition when the actual scanning is done on a patient. Then we have the image reconstruction where the axial slices are reconstructed into sagittal, coronal. And then we have our image display where it's displayed on the monitor for the radiologist to view in whatever plane they prefer.
Gold star, by the way, on that slide, guys. Maybe an example of one of your multi-answer questions you might see on the registry. Which of the following are involved in the formation of CT images? Those 3, red is the text there that you want to select. Each of those do break down further into a lot of processes we're going to discuss in the coming weeks. That's the general overview right there, those steps for forming a CT image. Big star on that.
All right, moving on. So, data acquisition refers to the collection of X-ray transmission measurements from the patient. So this is talking about when the patient is actually being scanned. All of that is measured by the detectors in the CT. That's what is data acquisition. And CT equipment has special electronic detectors that measure the attenuation of the X-ray beam as it passes through the patient. So that is data acquisition. You might be familiar with these. All right, so the first CT scanner required the X-ray tube and the detector to move in a straight line across the patient's head. And nowadays, newer generation CT scanners resolve the time issue by allowing the tech to acquire a volume of tissue with continuous rotation of the X-ray tube and detectors. That is called spiral CT. So back when CT first started, the X-ray tube and detector just moved straight across the patient. There was no rotation. But nowadays, we have what is called spiral CTs, where the X-ray tube and detectors are continuously spinning around the patient. So it makes it for very fast acquisition of images. So like I mentioned earlier, the data that's collected by the detectors when the patient is being scanned, it is sent to the computers for immediate processing. That's how the images show up rapidly while the patient's being scanned, correct? It's not like the patient is scanned and then 10 minutes later we have the image. It's all continuous, correct? Because the detector is communicating with the computers at all times. And that is why computers are vital to the reconstruction process. And it uses very complicated mathematic techniques called image reconstruction algorithms. That's also a gold star question.
Yes, that was, I'm guessing, on your test too?
Yes.
That was on my test too, that second bullet point, almost word for word.
All right. And after the image reconstruction process is done, the image display can be done for viewing on the radiologist monitor in whatever plane, sagittal, coronal, axial. And the images can be manipulated, stored, or recorded for whatever purpose. So the image manipulation is also known as digital image processing. Those of you who are in X-ray, this is kind of a similar concept. You can process the image once it's already been acquired and displayed. And some of the examples are smoothing, edge enhancements, grayscale manipulation, and 3Ds. So the images, the scans that are done, you can manipulate them in several ways to view whatever the radiologist requires. For example, 3D processing, like Wilson showed pictures earlier, you can view vessels, whatever bony anatomy that you may need to see. And images can be stored and recorded in some form of archive, examples in X-ray or X-ray film, or magnetic tapes and discs. This is also a question that you might see on the registry. And we know about DICOM. It's a standardized language used by different healthcare settings to, it's used as a standard protocol to facilitate networking among sending and receiving computers. So this allows the transmitting and information sharing of images and stuff. And we know, we should know what PACS does by now. We're in the healthcare field, right? All right. And Mr. Donahue will take over from here.
I should have been like that TSRT guy and have my papers. That's my turn to go. All right. Let's see, guys. So I think my coffee's kicked in. Let's see how I do here. So just a little, well, some of y'all probably already know, but man, I tell you what, when 5 o'clock hits, my body starts going zoom like this. So give me a few weeks, I'll get in the groove with this teaching thing late at night, but let's see how we do here. We're about to wrap up this portion of the chapter and get to the patient care aspects, which mostly is going to be a review of things you should already know about. But we do have to review it since you'll be administering a lot of contrast. So how do these CT scanners work? Right now, this is not going to mean much to you because you have not studied it yet. But this diagram here, and one of the ones I sent you in that toughest stuff PowerPoint, where it's showing the actual process of how an image is formed, is vital to your registry. Gold star on this slide and gold star on the one I sent to you last week. What is the imaging chain through the equipment? How does that image actually form? It's actually much more complex than simply using X-ray like we've all grown accustomed to. So we're not going to talk too much in detail about this yet, but next week we're going to break down each of these processes one by one of what happens from the beginning all the way to the end until we see that image on the screen at the very end. A lot of steps, a lot of little pieces to it, but we'll get you there. And there's some really good diagrams, and I encourage you on that PowerPoint I sent you on the imaging process, learn how to draw that diagram. It's one of the first things I did before I took my registry because I had trouble memorizing this myself. There were so many little parts to it. But remember the process, draw your pictures, learn how to do that. That's going to help you because you're going to at least get a handful of questions on that imaging chain. I can guarantee that. All right, so the basic steps to familiarize yourself as a technologist. Like I said, we're going to expand on this greatly next week. This is a general overview. Of course, you got to know how to turn the machine on. Yes, most of the time when you get there, it's already going to be on. But that's part of our daily duties as X-ray technologists. But from that, quality testing. Quality testing is actually quite complex on CT side compared to X-ray. You're going to see these little phantoms that they use in the mornings. And actually, that's one of the rotations that you can acquire is the quality testing. If you're going to be going on a morning shift, have them show you how to do that. It's a very easy one to acquire. They do it every single morning. They use those little water phantoms. You'll see what I mean starting next week if you're in the morning shifts. That's one of those nice, easy ones to acquire right off the bat. Of course, place the patient in the scanner opening that we call the gantry. That's our big donut. It's called a gantry, not a donut. And using the appropriate positioning for protocol. You'll see very quickly that not every patient is just simply laying on their back with their hands by their sides. Sometimes we raise the arms, sometimes we put one up, one down. It depends on what we're looking at, depends on where the IV is, things like that. Now, one thing I want you guys, and we're going to talk more about this in a minute, to really familiarize yourself with next week is how those power injectors work. If one of those CT techs tries to get you to do that right off the bat, I would recommend you don't do it because so many things can go wrong with those power injectors and you need to really learn how that works and be very careful in how it's being administered. Think about for a second, when you're injecting intravenously by hand, you're in control of how fast that contrast is going in, right? Those power injectors are going to inject at an extremely high rate, really fast, and there's a lot of things that can go wrong, namely what's called extravasation. You'll remember that from patient care, extravasation, that contrast doesn't go in the vein, forms a bubble on the arm. You want to avoid that happening because it can happen very easily. I'm way off track what we're talking about here, but I jumped ahead. But make sure you familiarize yourself with those power injectors before you even touch them. Very, very finicky devices and a lot can go wrong. Certain technical factors, yes, even though CT is mostly automated, computerized with techniques, there are some manual techniques we can still set ourselves. They'll show you how that works. Scanning with the X-ray tube and detectors inside the gantry rotating around the patient, self-explanatory. The attenuated X-ray beam is going to be measured by those detectors that convert that data into electrical signals, making that image in those complex algorithms that Ms. Bonilla just talked about. Those electric signals are converted to digital data for the computer. And the computer itself, I put that in red because that's a registered question right there. The computer itself is what is going to perform the image reconstruction process, sometimes shortened to image recon. You'll hear the text say image recon, not image reconstruction. Then the digital image is converted to electrical signals in order to be viewed by the tech on the monitor, and then they're sent to PACS or stored on those optical discs. This is a very general overview of that actual process of forming that image. We're going to further explain each of those steps starting next week. Start knowing the order of that process of how that works. Detector is essential to the CT system. Why? We wouldn't get an image without a detector. That's how we get our X-ray images. CT operates on the principles of X-ray. It's the same thing. It's just spinning really fast around the patient. It's going to absorb that radiation, convert it to those electrical signals that become digitized, then sent to the computer to create the actual image we see on the screen. Gold star question right there. This was on my registry. There are two categories of detectors that we use primarily in CT, that being the solid state detectors and the gas ionization detectors. And we'll go further into what the actual composition of those are, just like we did with X-ray cassettes, but that'll come in the following weeks. But for now, that's your two categories of detectors. Make sure you know them by name: solid state and gas ionization. Our generation, there are multiple generations of CT machines. As the technology advances, so does the generations. First generation is that one Ms. Bonilla told you about, where it was just doing a simple scan over the head. A lot of these images, as they started doing the spinning action, they would take an image, stop, take an image, stop, take an image, stop, and it would take a very long time to get those axial images that we see in CT right now. As of what we're using currently in the clinic, third generation is the gold standard. Even though we have a fourth generation type machine, that's usually for more specialized type exams. Third generation, and that is a registered question again, by the way, third generation is the gold standard CT machine we are currently using, which is a rotate acquisition method, where we see that really fast machine spinning really fast, getting all those images really quick. That's our third generation devices that we're currently using. And like I said, fourth generation is there. That's more for your specialized type exams though, for special procedures, cardiac procedures, things like that. You'll see a lot about pencil beams and fan beams. What I want you to remember is the fan beam is what's utilized by third generation. That is how we're acquiring the images, through a fan beam technology. We don't use pencil beams anymore. It's the old school way. All right, when we acquire these images, we're going to talk a lot about a term called interpolation moving the next few weeks. Does anybody off the top of their head remember interpolation? We talked a little bit about it in X-ray. What's that mean? What's interpolation? Anybody?
Jump between slices.
Basically, we're filling in the gaps. As we're acquiring those images with that spiral action, we're getting tons and tons of images. The computer is so advanced, it can fill in the gaps and formulate images from data that's not there. That's basically the simplest form of interpolation. But we're going to go further into that as we move forward. For now, know that the actual motion of that beam is that spiral or helical motion. It literally makes a spiral around the patient. It's not just plain circles. It's literally going to spiral like a big slinky. All right, multi-slice CT. That's based on what we call multi-detector technology. It scans 4 or more slices at a time per revolution. And that is one of the more advanced types that is coming out in modern day today. But like I said before, we're still mainly relying on those third generation type machines. That's kind of the gold standard that we still purchase. That's going to be the more cheaper option for hospitals while still delivering quality, high technology X-rays. What's the future hold for CT machines? They're moving towards what they call CT scanners with two or more X-ray tubes. The third generations are utilizing 1 tube and 1 detector, moving really fast, but they're trying to do multi-tube, multi-detector ones as well, just to speed up that process, so they can charge you lots more money for those exams. So they got to make some money too. True story. Those of you that know me know that I'm not a fan of CT. I think it's an overused medium that they take advantage of a lot on people. It's like a cash cow for hospitals. If you ever had a CT bill come in the mail, you know what I'm talking about. My wife's had multiple CTs. They're very expensive, even with insurance. But, you know, it keeps us employed. It's fascinating technology. Dual source CT, that's going to be a scanner that has 2 X-ray tubes and 2 separate detector array components. That's used primarily in our cardiac exams. Gold star question there, guys. When it comes to a cardiac exams, we're going to specifically use a dual source CT machine. Need to know exactly how it works, but when you see anything to do with cardiac work, dual source CT scanners are the way to go. That's our gold standard on those specific exams. I'm sure you've all heard by now, you know, I got to do my little CT rant. How many doctors say, oh, just send them to CT, just send them to CT, just send them to CT. It's always that go-to. All your physicians out there. Fry those patients, make that money. It's a high dose exam. We'll talk about that too in the next coming weeks, about how high that dose is. All right, applications for volume CT. If you see the word volume CT, these bullet points are why we would do volume CT. That would be for your fluoroscopy exams, 3D imaging, your angiograms, endoscopies, which would be a virtual reality type imaging, cardiac CT once again, and for CT screening exams. That's for volume CT. Angiography, what is that? We should know what angiography is by now. That's when you're imaging the blood vessels. That's pacified by that contrast media administered intravenously. Virtual endoscopies is an actual virtual reality program that hospitals can purchase for their machines. Costs a pretty penny to put those in there, but they can get a virtual reality look inside those tubular structures. Pretty fascinating if you've never seen that before. Really cool technology. Virtual reality is the way of the future, where a lot of these machines are evolving to. I expect that to become more and more popular as we move forward. We are virtual endoscopies. Cardiac CT, so as you know, guys, the heart beats quite fast. It can be very difficult to capture an image without the motion. That's the beauty of your cardiac CT imaging. That technology has advanced to the point where it can capture that heart even with it beating fast. It's going to do that without compromising what we call the spatial and contrast resolution. By the way, anytime we start talking about spatial and contrast resolution, we're going to hit that quite hard over the next few weeks. That's something you get a lot of questions on your registry about how good does CT handle spatial resolution? How good does it handle contrast resolution? What's the difference between the two? We're going to really break that down moving forward because that's going to be a large amount of questions on that concept. Yes?
Another example of question you guys may see is what advantage does CT have over MRI?
Yes.
CT has better contrast. MRI has better spatial.
Mm-hmm. So like she's saying, anytime we're mentioning that, you want to write that down because they ask you a lot of questions on that concept. Spatial versus contrast resolution. Once again, cardiac imaging. Anytime you see the word electron beam scanner, EBCT, that showed up on my test, that is related to your cardiac imaging. Another one of those machines they love to use for cardiac imaging specifically. We talked about the dual source and the multi-slice, but also your electron beam scanners. All right, CT screening. I'm actually not too familiar with that. Have you done that before, Ms. Bonilla? CT screening? Did y'all ever do that in MD Anderson? It's apparently a controversial method being used out there.
Well, they're just talking about using CT as a screening method to detect cancers.
Okay. So obviously the reason that would be controversial, why do y'all think? Is that how high dose CT is? Very high dose procedure. Should that be a screening tool? Yes or no? That's what's up for debate right now. The dose wars, I call them the dose wars going on. It's probably the biggest debate in the world of CT. CT, even though this technology has advanced massively, CT is still extremely high dose in comparison to your X-ray exams. X-ray's going down, CT's kind of just not evolving that much on the dose. It's still very high dose. All right, for those 3D images, they're going to use specialized algorithms. These are actually programs that have to be purchased by the hospital and installed on the CT devices in order to do that specific type of image. Very cool if you've never seen it before. If you have a chance to play with those, very neat. Your tech will probably let you manipulate the images if you ask nice enough. Some of these programs are so advanced you can do dissections on them. You can pull parts, move them around in 3D space. It's really neat to see. I encourage you to try that out if your tech will let you. How's that happen? 3 important steps. Gold star question again, guys. When it comes to making a 3D image, it's going to use what's called volume formation, classification, and image projection. Now, if these don't make much sense right now, we're going to go into those further in the next few weeks as well. This is more of a general overview once again. Volume formation, classification, and image projection. Remember, I played with an image like this when I was in school. Really cool to take apart something, move them all around. It was still kind of a newer technology, so it kind of moved like frame by frame. Now it's like really smooth when you're manipulating those images. It's advanced so much. Really neat to see. All right, digital imaging processing. That's going to be the use of a digital computer to process and manipulate your digital images. And in radiology, it allows us to allows the observer to process images to enhance diagnostic interpretation. Everything is going digital. And that image on the right is just another example of that imaging process that we're going to be memorizing over the next few weeks. There are multiple ways you can draw that, but you want to really familiarize yourself with the order of how that goes. But we'll explain that starting next week. But you do want to know how all this works, what the order is, and what each of these boxes mean moving forward. Let's just show you some digital imaging processing right there. That's some virtual CT endoscopy images. I had an endoscopy done recently, but it wasn't by CT, it was just a scope. All right, radiation dose study. So of course, guys, we're always wanting to provide maximum info with as little dose as possible. That does become much more difficult with CT because of how high dose it is. But it's also why it's so important that we know exactly what we're doing, because the last thing we want to do, we don't want to do repeats in regular X-ray, but we really don't want to do repeats in CT. That can be a big deal, and if people are knowledgeable of dose, they're very likely to give you a malpractice suit or sue a hospital for a repeated CT image. Because most people, when they hear about CT, they hear about how high that dosage is. So ALARA, guys, I hope we know what ALARA is still. Believe it or not, you might see that on your registry still. Please make sure you know what that means. We know what that means still, right? It's not that old, is it? It's not just a name. Dose reduction, guys, what does that mean? That's the reduction or diminishing in size and amount of the extent of radiation. Dose optimization, we're making something as fully perfect, functional, and effective as possible without compromising that high dose on the patient. Reduction and optimization. Radiation dose schemes. Let's see here. Yes, pre-patient filtering technique. I know why I put this in red, guys. This was a registry question on my exam. What is the best factor in reduction of dose on a patient? You're going to see multiple answers on that. One being the bow tie filter. If you see bow tie filter, that's your number one answer. But if you see this answer as well, this would be your second best choice, pre-patient filtering technique. If they're not using the word bow tie filter, you're going to pick this right here for the best method to reduce dose in CT. Those are installed in the machines themselves. So number one dose reduction is doing your bow tie filter. Number two is your pre-patient filtering technique. We'll be talking about that with pre-patient collimators, things like that, in the next few weeks. Also, it's called an automatic tube current modulation technique. This was also on my registry. I put that in red. That's going to automatically adjust the MA based on the patient's characteristics. How big are they? How thick are they? That algorithm is advanced enough that's going to automatically reduce that MA and reduce that dose for us. And then quality control, like I said, they're going to use those phantoms. They're usually called water phantoms. There's all kinds of neat looking phantoms you'll see. That's going to make sure that your machine's working properly, make sure it's administering the proper dose and not barbecuing our patients out there. Easy little rotations to get to add to the ART. If you go in the mornings, once again, you'll see them doing those, or they should be doing those every morning. All right, guys, patient care. Let's go over some of these patient care aspects for contrast administration, since you will be administering contrast to your patients. As I said, a lot of this should look very familiar to some of you guys. So these are the same exact slides I used in patient care. But most of this should be reviewed with a few new concepts here and there, but we do have to go over this with you. What's parenteral mean? That means the drug's been administered by penetrating the skin. Parenteral. Thrombocytopenia. Very important definition. This is an abnormal small amount of platelets in the circulating blood. Thrombosis is clotting within the blood vessel itself. Toxic reaction, that's a life-threatening effect of a drug that may occur immediately or over a long period of time after that particular drug administration. Vasodilation, widening of the blood vessels. Should all sound familiar so far, yes? I'll review. Widening of the lumen of the blood vessels. Vasovagal response. That's an action of that vagus nerve upon blood vessels resulting in a rapid pulse, cold sweats, bradycardia, hypotension, and syncope. What's bradycardia, by the way? Slow heart. What's the opposite of that? Tachycardia. What's hypotension? Hypo's low. Hyper's high, right. I'm feeling hyper right now because that coffee's kicking in. So if I'm talking too fast, tell me to slow down. All right, drug. We know what drugs are. We use them every day in our career. Some of us take them, recreationally. Probably shouldn't do that, but, drug is a chemical agent capable of producing biological responses in the body. Sometimes good, sometimes bad. These can be desirable, therapeutic, or undesirable, what we refer to as adverse. Even our contrast mediums can become adverse, which is why you got to be so careful and know how to recognize those adverse reactions, because write this down, put a star on it. The first thing you always do if you have an adverse reaction to any kind of medication, well, you tell me, what's the first thing you do? You stop the procedure immediately. Don't run over and check on them. You stop what you're doing. You stop the flow. You stop the machine. You stop it all. You always stop everything if there's an adverse reaction. That's on your registry, by the way. Know that. That should look familiar, guys. Are different ways of administering drugs parenterally. The most common being intravenous. We're going to use that 25-degree angle. We're still going to do that just like we learned how to do venipunctures in X-ray school. Same concept for CT. Probably most of you acquired your venipuncture comps during your CT rotations or your MRI rotations. And of course, that's all your different routes of drug administration, of which there are many, guys. That should all be reviewed. You've all seen that before. Once again, the most common one we're going to use in CT is that intravenous or parenteral route. All right, if we're administering a drug, we got to know all these responsibilities. Of course, safe dosage, how much are we giving the patient? The safest route, which kind of vein are we using for that study? We don't use a weak vein because what's going to happen, it's going to explode. We're going to have extravasation of the contrast outside the vein. Limitations of the drug administered, the side effects. We must know what that drug can do so we can recognize it if it happens. Potential adverse effects, the toxic reactions, and of course the indications and contraindications. What are contraindications, by the way? Why is that so important? What's that mean when I say contraindication? Reasons not to give the drug, exactly. All right, if it is administered because of lack of knowledge, the person who administers the drug, you are legally liable. So if you cause an issue with the patient by using that drug wrong, hospital's not in trouble, you're in trouble, your license is on the line. Which is why we gotta learn to do this correctly, because so many things can go wrong if we're not very careful. So you must demonstrate competency before administering drugs without supervision. Through your whole tenure here, guys, of going through this program, we typically say, we're just going to say, don't administer drugs by yourself in CT. Make sure they can see what you're doing, because so much can go wrong with those power injectors. You just want to make sure they're within eye shot and see what you're doing. When you become a tech, hey, you're on your own doing your thing. But as a student, protect yourself, because it can be very, very volatile if we're not doing things correctly on contrast administration. We should know this, guys. I put a star on that because that is a registry question, just like in X-ray school. 5 rights of drug administration: right patient, right drug, right amount, right route, and the right time. You must always document all that accordingly. Be careful on the right drug. We're going to show you some examples of the contrast mediums that we use, guys. Make sure if the tech tells you to retrieve contrast that you know what you're retrieving. Don't just make an assumption. Please be careful, because you could inadvertently cause a lot of reactions to the patient. If they say, go get me some Omnipaque, make sure you're actually getting Omnipaque. Be very careful. Look to the colors of those little bottles. Pay close attention. That's just those same 5 rights there, guys. Just spelled out a little bit more for you. Move forward here a little faster. So how can drugs affect us physiologically? They can alter our blood pressure, alter our heart rate, bradycardia, tachycardia. alter our urinary output, functions of the CNS and the PNS, of course changes to our other body systems. All review still. You should all still know this. Pharmacodynamics, very important definition there, guys. It's the study of the method or the mechanism of the drug action on living tissues or the response of the tissue to the contrast agents themselves in various sites of the body. Very good definition to remember there. Pharmacodynamics. So we're going to get a lot more into pharmacology than we did in X-ray school because there is so many more different contrasts that we're going to administer through CT. Whereas in X-ray, we're just pretty much used to barium. Give them some barium. If they can't take barium, we're going to use a water-soluble contrast. Use non-iodinated contrast. Some of those overlap a little bit with CT, but there's a little bit more to it. All right, pharmacodynamics as effects can be of three categories, that being therapeutic, diagnostic, and adverse. Of course, number 3 is what we're trying to avoid. Adverse would be a bad thing. Brand versus generic. We should all be familiar with this. Who's bought, off-brand Tylenol before? We all have. Acetaminophen. You have the brand name, the generic names. Basically, guys, they're typically exactly the same. Just one's going to be more expensive than the other. Brand names versus generic. We should all be very familiar with that. That's the same thing with contrast. You have brand name contrast, you have generic contrast that can be used. Both are considered safe to use. That's just expanding on the same thing there, guys. All right, intravascular radiopaque contrast media, ROCM. You will see this long word abbreviated to ROCM a lot moving forward. Make sure you know what that's referring to. Diagnostic effects. They are a function of the iodine contained within the ROCM. Adverse effects depend on the serum, the tissue iodine concentration, the osmolality, and their calcium chelating anticoagulant and immune system stimulating abilities. That was a mouthful. But one to really pay attention to there, guys, is the osmolality. I do remember that showing up on my test. They referred to osmolality quite a bit. All right, so our high density agents, what do we use those for? That's for our low contrast tissues in the body, like your vasculature, your kidneys, your GI tract, and your biliary tree. That's your high density agents. Your most frequently prescribed contrast, ROCM, is going to be your iodine and your barium. So yes, we do use barium sometimes in CT, mostly for your barium enema studies. They do CT barium enema studies sometimes. I didn't see any of those while I was in CT school, but they do exist. All right, how can we administer ROCM? Well, of course, parenteral versus enteral. They can be ionic versus non-ionic, and high osmolality versus low osmolality. So this should be pretty fresh, guys. 3 and 4. Which is the preferred one that we want to use out of 3 and 4? And why? Would we rather do an ionic or non-ionic contrast medium?
Non-ionic.
We want to use non-ionic preferably. What's the main reason? That's a good test question.
This reaction.
There's less chance of an allergic reaction with non-ionic contrast mediums. Why? Because the ions do not dissociate, whereas ionic, they do dissociate, causing those issues, causing those reactions. Same token, we want something with low osmolality, preferably. And depending on allergies, they have to use different types of contrasts, but preferably you want to stick with those non-ionic contrasts. All right, so every contrast will have properties of that osmolality and viscosity. Viscosity is a very important term. I wish I could put that in red. What is viscosity referred to, guys? Very important definition there. What's it mean to be viscous?
I heard an answer back here.
Speak up, because I can't hear. The thickness of the contrast, how thick it is. So you'll notice when you go into CT departments that those contrast beams are being put in a heater that's to lower that viscosity to allow it to flow through the veins a little easier. You want to keep that temperature when it's being administered. You don't want to set the contrast out on the table, let it get room temperature, because it's going to become more viscous, more thick, real syrupy. So you want to have that certain temperature to be nice and thin to travel very well. Types of contrast, again, ionic versus non-ionic. Non-ionic is always going to be your more desirable choice, less reactions. There we go, guys. If it's ionic, it's going to have higher osmolality. Non-ionic, lower osmolality. So you can see multiple ways they can ask those questions. Of course, preferable, once again, is your non-ionic plus your low osmolality. It's going to give you the lower risk of allergic reactions, less risk of complications, and it's just overall the better choice. Now, one thing to always keep in mind, non-ionic contrast mediums are more expensive than ionic, so depending on the hospital, they may opt for either, but most of your hospitals are smart enough to know ionic's not worth the risk. They're going to opt for those non-ionic, even though they cost a lot more money. That's just some examples of the types right there, guys. So these should look familiar: Visipaque, Isoview, OptiRay, Ultravist. There's your Conray and Hypaque. Osmosis, very important definitions here, guys. Like I said, osmolality came up quite a bit on my test, but osmosis is another important one. Excuse me, that's the water moving across a semi-permeable membrane. Osmolality is the number of milliosmoles per kilogram of water, or the concentration of molecules per weight of water. That second definition is the one that I saw. The concentration of molecules per weight of water. Radiolucent. Oh, y'all can teach this to me right now, huh? We know what radiolucent is, right? What's radiolucent? Easily goes through, right? What's radiopaque? Blocking it, it's absorbing it, it's not going to see that bone, see that metal. Hyperdense, blood, calcified soft tissue, bone, densely collagenized tissue. That's your best examples of a hyperdense type of body within the body. Hypodense. This can be an area that does not enhance well with IV contrast. Some structures in the body are what we consider hypodense. It's escaping me off the top of my head. Can you think of an example of a hypodense structure?
Areas that don't get in as well.
Don't really eliminate the contrast very well. My mind went blank on that one. There are quite a few structures that you cannot enhance well with contrast. We'll review that because it escaped my mind. I apologize. Isodense, that's going to be tissues that have similar densities. Keyword there, guys, when you see the word isodense, similar. Similar to another adjacent tissue. Very good keyword there. You may or may not see that. I seem to recall seeing that somewhere on my test as well. Isodense tissues. All right, some patients are going to require what we call pre-medication, especially those who have had an experience of a mild reaction before previously. Very important before you do an exam with contrast that you look for the history, because not everyone's going to catch these things. If they've had some kind of prior reaction, we've got to make an adjustment to the contrast we're giving them. Make sure we don't cause that reaction once again. Now, mild reactions, that's going to be hives, your nasal congestion, itching, and mild shortness of breath. Severe reactions, big deal. My goodness, if they've had a severe reaction, please don't give them the same contrast. That's going to be things like our laryngeal edemas, severe shortness of breath, and anaphylactoid response, which can lead to anaphylactoid shock. Yes?
If the patient has had previous CT exams, and
Uh-huh.
they come in for a CT exam and they have an allergic reaction, could that be something new?
It could be. It's not necessarily going to be a history. It might be their first CT exam, so we don't know sometimes. But we've got to be able to recognize these immediately, because if you see any of this happening, mild reactions, typically it's kind of normal. Minor is not going to really be life-threatening. So if they're itching, you're not going to stop the exam because they're itching. If they're feeling hot, you're not going to just hit the stop button. The tech's going to throw you out, first of all. Don't do that. But the mild reactions, we expect them to have a metal taste in the mouth. You'll hear people say all the time, oh, it tastes like metal in my mouth. Totally normal. I feel really hot. Is that okay? Totally normal. Some people might freak out. One thing that my tech taught me when I was in CT school is always tell them that that can happen. You may taste metal in your mouth. It may make you feel warm. You may feel like you pee on yourself. All normal things to happen. Don't freak out. Some people don't tell them though, but you want to do them a favor and tell them that. But if these things happen, like they're getting real severe short of breath, like oh my god, I'm in pain, they're like screaming on the intercom because you have a little speaker, then you're gonna hit that stop button, stop what you're doing, and go check on them immediately. Because it can happen. I saw it happen one time when I was in CT school where someone was having severe pain all over their whole body. We had to hit the emergency stop. I saw a couple of what did I just say? The extravasations where it bubbles up. Stop what you're doing immediately, get them a warm, hot, cold compress, help that swelling go down. Very painful, very uncomfortable, as you can imagine, if your skin's bubbling up full of contrast outside the veins. That can happen. If you're going to LBJ, make sure y'all check those lines. Your tech's gonna probably teach you right off the bat how to flush the lines properly with saline. Make sure they put those needles in properly, because the extravasations that I saw at LBJ were due to the nurse not putting the IV in properly. It wasn't our fault, it was their fault. But you always check those lines first, especially those power injectors. It's shooting a lot of contrast really fast. Pediatrics, pediatric dose, that's gonna be based on the weight of the infant or the child. That's a gold star question. We vary that based on the weight of the infant or the child. Most common formula for that is 2 milliliters per kilogram. That was on my registry. 2 milliliters per kilogram. Adult dose, there's usually a uniform dose for each protocols, but in some cases, weight basing the dosing can have advantages. That's dependent on your facility, if they do that or not. Most of them it's just a standard uniform protocol for the dose. All right, when a drug produces an effect that is mild, common, unintended, and non-toxic, that's a normal side effect. That's your hives, that's your warmth, that's your metal taste in the mouth. Life-threatening will be our adverse effects that we do not want to happen. They can lead to actual death, severe allergic reactions, pain, damage, all the above. Side effects versus adverse, we should know the difference between those. They are not the same. Side effects are normal, we expect that. Adverse effects we do not want to happen. Big no-no. Of course, I'm hoping none of us have experienced this before, but overdose of a drug can happen with any kind of medication. Don't raise your hand if you've overdosed before. I don't really want to know. It can happen to the best of us. But that can become toxic and or life-threatening, of course, as well, because of those adverse reactions. Drug tolerance, we know what that is. You take too much of a drug, your body begins to develop a tolerance for it. It's not going to have the normal effects after you've taken it for too long. And tachyphylaxis is the rapid development of tolerance to a drug. Can happen to some people. Tachyphylaxis. We're doing okay, guys? All right? All right. Adverse effects continued. Contrast reaction. Many different things can happen, guys. Once again, side effects are going to be your things like your heat, metallic taste. Not a bad thing. You're not going to stop the exam because of that. Just inform them beforehand that that can happen. But serious effects can happen. That's going to require you to stop the exam, require treatment, be life-threatening, call a code, whatever the process in your hospital is. Make sure they tend to that immediately because people can die from these exams. Anaphylactoid, that's a gold star reaction there, guys. Probably the worst adverse reaction that we do not want to happen is anaphylactoid reactions that become anaphylactoid shock. That's going to be the typical outcome of that is going to be your acute bronchospasm, profound hypotension, and severe urticaria. Can be life-threatening, not always, but very serious. That can occur with as little as 1 milliliter of contrast, by the way. Just 1 milliliter. It's a tiny amount. Not considered a true allergic reaction, and there's unclear etiology on that. They're still trying to study exactly what causes that with people. Dose-dependent systemic adverse reactions, those are typically non-life-threatening. Self-limiting problems, that's going to be your normal side effects. Your nausea, your vomiting, your metallic taste. A little bit more serious than a side effect, but not life-threatening. Now, really, one of the big adverse effects we have, guys, is renal failure. You're going to learn about how the techs do check things like your BUN, your creatinine levels, because if there's anything that's off, we're not going to do these exams because you're going to have the risk of that severe renal failure, which can actually kill the patient as well. So be very careful on that. Your techs will show you how that works, how to identify those values. If they notice anything's off, they're usually going to reschedule that exam or do some kind of alternative for the patient. Because renal failure can happen very easily if those values are off. Your patients at a greater risk are the ones with a pre-existing renal insufficiency. On the history, if you see anything to do with the kidneys, guys, and keep an eye out for this. If there's anything off about the kidneys, the first thing you should do is what? If you get a patient and you look at the history and they say they have a previous history of renal insufficiency or renal problems, what is your duty as a tech to do immediately? What do you do? Or if they say, hey, I've had kidney problems before, and you're talking to them, what should you do? Who should you talk to? the radiologist. You want to call the radiologist and say, hey, do you want to proceed with this exam? You just say no, absolutely not. Make sure you communicate that. Don't just say, oh yeah, you'll be all right. We get kidney problems all the time. Get on the table. It may not end well for you. Make sure you communicate that properly. Let the doctor know. Diabetics, high risk as well. And your dehydrated multiple myeloma patients. Dehydration does present a large risk in CT exams. You need to be properly hydrated. Delayed reactions, this is when an adverse reaction happens post-injection, about 30 minutes is the typical time period. That can happen as well. That would be a delayed reaction. Most commonly, it's going to be flu-like symptoms, fever, chills, nausea, vomiting, abdominal pain, fatigue, and congestion. More common with your ionic agents, this is why we try not to use ionic agents. On ionic, by the way, ionic agents, 30% of your patients react. Non-ionic, the safer option, only about 10%. Always much safer in comparison. Excuse me. Some more conditions associated with your adverse reaction to contrast. Once again, renal insufficiency, anything to do with the kidneys, big red flag, guys. Pay attention to that. Previous anaphylactoid reactions to contrast. Have they had a previous reaction before? You want to make sure you investigate that. Asthma, food or medication allergies, or hay fever. Big red flags, multiple medical problems, underlying disease. Treatment with nephrotoxic agents, and of course, advanced age is a factor as well. Remember these. This is off that Tough Stuff PowerPoint, by the way. I'm going to send you this. All right, how do we prevent contrast-induced renal insufficiency? We're always going to opt to use the smallest amount of contrast possible. Registered question, guys. Gold star question. Always use the smallest amount of contrast possible. Discontinue other nephrotoxic medications before the procedure and allow 2 to 5 days between procedures requiring contrast. If I remember correctly, I almost had this question word for word on my test. It was a multi-answer question. We had to select all 3 of those. Very important concept right there. Preventing renal insufficiency. Kidneys do become compromised quite often in CT. Documenting. You guys that have been my students before, you know how I always harp on documenting. Don't let up on the documentation. You need that paper trail on everything you do. At minimum, the elements of documentation should include the amount and type of contrast injected. Should be familiar to us who've worked fluoro before. We have to do that for every case. The signs and symptoms of the reaction, interventions or medications given during the reaction and the patient's response. And then the final outcome, whether they were sent home or admitted to the hospital. 4 major factors that we want to document if anything does happen. Now, regardless, you're going to document that contrast on every exam, period. Don't ever forget to do that. I can come back and bite you in the rear end if something is to happen and you didn't document it properly. Renal function. So clearance, that refers to the ability of the kidney to remove a substance from the blood. How do we estimate that? Those 3 values you see up there on those bullet points, your GFR, your ERPF, and your SECR. So typically the SECR is what's used the most because those other 2 can be quite cumbersome, but they can be estimated using all 3 of those. I don't recall these 2 showing up on my test, but they did ask me about GFR on my test. What's the proper GFR values? All right, we're getting close to the end here, guys. There's light at the end of the tunnel, I promise. Indications for the use of contrast media. Of course, the brain. Why would we use contrast media for the brain? To highlight the vascular structures that we can't normally see and to indicate disruption of the blood-brain barrier. Chest. Well, we do it for chest. We want to see masses, pulmonary emboli, enhancing that aorta and the other vessels of the mediastinum. That aorta, guys, when it comes to anatomy, know every bit and piece of that aorta. We'll talk more about that in the coming weeks. We didn't really study much about the aorta in X-ray school, but in CT, you got to know all the parts of the aorta and those branches coming off of it. We'll master that as we move forward. Abdomen and pelvis. We got to look at those abdominal and pelvic organs, vascular structures. Contrast will allow us to do so. For the spine, the masses, an evaluation of a post-surgical spine. Your musculoskeletal studies, vascularity of a lesion. How do those vessels relate to one another in the musculoskeletal masses? And of course, the vessels in trauma patients to check the integrity of those vessels. All right, I think I already hit that on the other slide. We'll move forward here. That's just a repeat of what we already went over. A few new ones there, guys. Just more did I talk about contraindications specifically? I want to skip that if I didn't talk about it. It's all running together here. All right, we'll hit it just in case. Contraindications of contrast, guys. Hypersensitivity to iodine, asthma, hay fever, your food allergies is a reason you would not want to give contrast to a patient. Congestive heart disease, liver or kidney disorders, big one right there. Kidneys once again. Thyrotoxicosis and hyperthyroidism, these words. Melomatosis, diabetes, anorexia, multiple myeloma, sickle cell, and good one on the last one. Pheochromocytoma. Man, say all those 10 times fast. Wow. All right. Why do we use a positive contrast? This is a review from X-ray again, guys. We use positive contrast to increase organ density and improve visualization. Why do we use negative? To decrease organ density, to produce contrast. Your most common negative contrast agents, your air, your carbon dioxide, and your water. Of course, your positives are like your barium, your ionated contrast mediums that we all use in fluoro. Same thing for CT.
Go back to the left slide. Make sure you guys know the atomic numbers.
You had that on yours? I'll be ahead on mine, but yeah, good point to bring up. You never know what they're going to throw in there. Those sick people, the mustache twirling villains I told you all about a little while ago, making those questions. What's the sickest, most demented question I can give them for a CT test? Twirling their evil mustache, that's what they do. They sit around in a boardroom and do that. I can't confirm that, that's my assumption. All right, your types of contrast continue, guys. Your radiolucent, that's going to be related to your negative contrast agents we just talked about. The X-rays will easily penetrate those. You're just going to look very dark. It's going to be the black structures on your CT images and your X-ray films. It's your air and your gas. What kind of complications can arise from your negative contrast mediums? Complications like emboli, air pockets in the vessels, lack of oxygen. Radiopaque, that's your positive we just talked about. Those absorb the X-rays. They appear very white on the images. That's going to be your bariums, your iodines. And of course, we can use both at the same time. What's it called when we use both at the same time, guys? Double contrast study. If you use just one, it's single contrast. All right, integral radiopaque contrast. When you see the word integral contrast, it's usually referring to an exam of the GI system. We do GI exams in CT. It's going to be using integral contrast methods for GI studies. Show you a few more examples there, guys. Of course, upper GI, you should all know what that is. Same concept for your CT. Positive contrast that's very white on the X-rays or the CT images. All right, how can these be administered? Orally, vaginally, rectally, IV, intra-arterially, intrathecally, and intra-articular methods. All common methods for positive contrast agents. CT, once again, most common method is going to be your IV method through the veins. Just for review, what's intrathecal mean? People always forget that one. What's the word intrathecal mean? So what's it, lumbar? You're on the right track. Wasn't that long ago, guys? Intrathecal? What's an intrathecal injection? Think of like a myelogram.
In the CSF?
Where's the CSF located? Subarachnoid space. Someone say subarachnoid space. Give me some hope here. Someone say subarachnoid. They're still not saying it, Ms. Bonilla. Someone say subarachnoid. Give me some hope here. All right, thank you. Okay. Subarachnoid space. All right, negative contrast agents, that's your radiolucent contrast mediums. They can be mixed for your double contrast studies. They can be used alone, but are never used in IV or intra-arterially. Why do you think that is? Common sense answer there, guys. Why would you not use a negative contrast agent in the veins? You're scaring me. Huh? I don't know about you, but I don't want to be injecting any air in anybody's veins. It's probably not going to end too well.
What would happen with air in the vein?
Kill somebody, yeah. Put it simply, yeah. So we're not going to put those in IVs or intra-arterially. All right, a few facts here, guys. Half-life of IV contrast, 10 to 9 minutes. 90% of contrast. Ooh, registry question 101, ladies and gentlemen. That was on my test. 90% of contrast is excreted within 24 hours on average. Your peak urine concentration is at 2 hours after the administration. That's when you're going to have to pee the most. Your iodinated contrast is classified as either ionic or non-ionic. What's the safest one more time, guys? Non-ionic. Why? Because it does not break down or form ions in the solution. That's why it's always the safest option. That means it's going to cause the least amount of reactions, the least amount of allergies overall. Ionic, why do they cause more reactions? Because they dissociate, and that's what leads to those reactions, those allergic, adverse, undesirable reactions we don't want to happen. All right, your ratios, guys. Oh, we have a ratio and a radio there. Typo. Ionic ratio to particles is 3:1. Ionic radios, should be ratios, I apologize, is 3:2. Your types of ionated contrast, your ionic highs, some examples once again, renographene, Conray, Renovist, Hypake. Non-ionic, the gold standard you're going to be going with in CT is that Omnipake. It's considered non-ionic, very safe, the least amount of reactions. You'll become very familiar with that contrast medium in particular. Of course, OptiRay and IsoView, many of us may have used that in some fluoro exams. And then isomolar type solution would be Visipake. I promise there's like 10 more slides, guys. Hang in there. See your eyes rolling in the back of your head. Types of non-ionic guys, I can never say that word. Iopamidol is another name for IsoView. If you're going to memorize any, know number 2. The alternate name for Omnipake is iohexol. They can use this interchangeably in the question, by the way. Ultravis is also called iopramide. Visipake is just called Visipake, thankfully. Iohexol and Omnipake, please know those 2 terms. They did use those interchangeably on my test. Of course, there's an example of your IsoView 300. Make sure you can tell the difference between this and this. This is what you'll be using the most, but make sure you confirm, because your text may or may not ask you, please go get me some IsoView, please go get me some Omnipake. Make sure you know what you're picking up, guys. If you don't feel comfortable doing that, you can refuse to do so. Just let them know. Don't just assume you know what you're doing. That's an example of your MRI contrast medication there, your OmniScan and your Magnavist. Iodine contrast is typically not visible on an MRI. High dose gadolinium contrast may or may not be visible on a CT. Which one offers the best beneficial tolerance to the patient? Of course, once again, your non-ionic, low osmolality is always your gold standard. Best for patient safety, less discomfort, and the least amount of reactions. Your dose calculations, on average, know these 2 numbers, by the way. Your adult patients need about 100 to 150 cc's of IV contrast. For children, it's typically calculated by 1 cc per pound. 1 cc per pound. They may ask you to calculate that on your test for pediatrics. 1 cc per pound. They do have some math on there, unfortunately. Yeah, that's what I said. I had the same exact sound come out of my mouth. Please no more math. All right, some lab values, guys. The serum creatinine, that's the test of the renal function. Showing us the balance between the production of creatinine and filtration by the renal glomerulus. Your BUN, blood urea nitrogen, we're going to check that as well. That shows us how well the kidneys are functioning. Measures the amount of nitrogen in the blood that comes from the urea. If the kidneys cannot remove urea from the blood, the BUN will increase. And your eGFR, your estimated glomerular filtration rate, your kidneys filter your blood by removing waste and extra water to make urine. GFR shows you how well those kidneys are actually filtering, thus glomerular filtration rate. How well is that filtration working? Now, when we have a GFR above 45, it's considered safe to use Omnipake. If it's 30 to 45, we use Visipake. You do need to know these values and what you use, by the way. They may ask you that. Below 30, you do not use contrast unless requested and cleared by a radiologist. 1 kidney only, you're going to use the Visipake. So they change that quite a bit between those situations. Yes?
Now, these numbers, I just put them up there because that's what we used at MD Anderson. These numbers could vary depending on which hospital you work at.
Yes, yes, you confirm that with the protocols of the place you're working. All right, your normal serum values, guys. For males, please know these numbers. Big star on this. Your male is 0.6 to 1.5 milligrams per 100 milliliters. Females, 0.8 to 1.4 milligrams per 100 milliliters. High levels of your serum values is going to indicate there's dehydration, urinary tract obstruction, renal failure, glomerulonephritis, diabetic nephropathy, or pyelonephritis. Doesn't necessarily mean all of them, but one of those things could be going on with the patient.
This is creatinine.
This
serum,
Yes.
is, yes, thank you. Yes, thank you. Creatinine levels, correct.
So normally, you would be able to draw a little bit of blood from the patient's IV, run it through the iStat machine, and then it would give you their creatinine, and from that you can calculate their GFR based on their sex and age.
Well, that's the one you put like the drop on there and then you slide it in the machine. I remember that.
Yes. Yeah. Your normal BUN, more important numbers, guys. Know that range for men versus women. For your men, 70 to 20 milligrams per. What's DL?
I'm sorry?
What's the DL stand for? Slip my mind. Maybe deciliter. I can't think off the top of my head. Maybe deciliter. 70 to 20 milligrams per mysterious DL. 5 to 25 for your women. Now, why do we do that? We got to see if the kidneys are, of course, functioning normally. Big red flag once again. Whether that kidney disease is getting worse. Monitor the treatment of kidney disease and determine if severe dehydration is present. Dehydration, once again, big deal when it comes to administering contrast during CT exams. Oh, do I have anything else? Nope, that's the end, guys. Made it through your first lecture. All right? A lot coming at you. We will send that to you, and I will send you the supplemental toughest stuff material that goes along with this lesson as well. You put yourself together your own personal registry study guide. As we tell you this information, start studying your anatomy for next week. Look over the brain specifically, get familiar with those terms. Start studying the CT imaging chain. We're going to hit that next week as well. Like I said before, we're going to get that boot camp to you guys as soon as possible. Like Black is working on purchasing that. We'll adjust those assignments accordingly for you guys. So don't worry about getting those due dates next week. Not going to be possible you don't have it yet, but we'll work on that moving forward. And don't forget, your clinicals do start next week. Are there any questions in regards to that? Any questions?
If you don't have a badge yet, how does that work? So I'm at OBJ and I know you badge in to get into these programs.
Right. You might have to go to security and get you some kind of like temporary something or another. Yeah.
Okay, so when I drive in, do I just let them know, hey, I don't have my badge yet?
If you're a student, yeah. Who's